Hi everyone, my name is Mike and I'm a PCN dietitian and research champion for MPFT. And this is a recorded version of my talk, which is called Make Diabetes Care Great Again. Now, if you're wondering, this is not a political stance. However, you can consider this a bit of a rallying cry for us to rethink and maybe change the way that we are approaching diabetes care in the UK and, of course, all across the world. And I'll explain why I think that needs to happen in just a second. Um, but before we dive into everything, I just wanted to share a very short story to try to drive home this point that perhaps the way we're approaching diabetes care at the moment is maybe misplaced and maybe misguided, and maybe we need to rethink how we're approaching the whole thing. So, for a moment, I just want you to imagine, as in the picture there, there's a river, and there's obviously a rural village living alongside the river. Now, of course, the people living in that village, they use the water for all of their needs, pretty much every day. Now, one day they notice that the water becomes really, really dirty, really bad tasting, and completely unusable. Now, of course, they're concerned about their water and obviously their health, so they contact maybe the local authorities or a local water expert who advises them to use a purifying tablet to clean the water for them. Now, they use the purifying tablet and it does actually work. It does clean the water for them and it makes it usable again. However, they continue to use the water in exactly the same way. So they're using it for their food, but also they're using it to clean their clothes, to clean themselves, literally everything, which is why the water got so dirty and unusable in the first place. Now, over time, they need to use more and more and more of the purifying tablets to keep the water clean, but of course the water just gets worse and worse and worse, and they can't really figure it out until one day one of the elders in the village sees what's going on and suggests, listen, instead of relying only on the purifying tablets, why don't we also take care of the river? Let's stop polluting the water upstream and find a better spot for us to wash ourselves and of course source our drinking water. So that's what the villagers do. They start taking better care of the water. They move where they're doing their washing and where they get their drinking water from. And over time, the water quality improves and they need less and less and less of the purifying tablets to get the same quality water. Now, of course, this story is completely made up and it is meant as a metaphor for managing diabetes. So if you imagine that the river represents our bloodstream, the purifying tablet symbolizes the glucose lowering drugs that we can use. And of course, the pollution is the poor dietary choices that chronically raise blood glucose levels. Now, much like the villagers were able to figure out how to, take care of the river and have the river in turn take care of them, I believe that people living with diabetes can learn to manage their condition without this increasing reliance on medications. And in doing so, they can, bypass a lot of the complications that come with diabetes, and they can achieve all of that through just more informed dietary choices. And we'll talk about what that looks like in a little bit. So I just want you to keep in mind this short story as we go through the rest of the presentation, because this really encapsulates the core message of just rethinking, what are we doing, why are we doing it, and is it time for change? Because in my opinion, now is the time to change things. You've probably seen various versions of this graph, but this is the increase in prevalence of people living with diabetes in the UK right up until 2022. Of course, by 2050, it's predicted to be a lot worse than this. Interestingly, the prescription of glucose-lowering drugs in the UK is at a 10-year all-time high. Bearing in mind that statistic was taken from a research paper dated 2009. So obviously since then we have new drugs. A lot more prescriptions have happened since then. Might be interesting to know that in the UK currently, as of 2021, the average HbA1c is 5.5. And of course 6% is considered pre-diabetes. So if we think it's bad now, it is sadly only continuing to get a lot worse. Also, sadly, as of 2022 in the UK, 1 in 14 people are living with diabetes. So the situation is continuing to get worse, despite the fact that we've never had access to more glucose-lowering drugs than at any time in history. And it might be, as in the story with the villagers and the river, it might be that because we're overlooking the fundamentals and not doing the fundamentals, and continually seeking more and more and more advanced solutions, which really just end up almost being a sticky plaster on the situation, as in the story with the river. And the statistics don't stop there, of course. So in the UK, every single week, there are literally more than 190 amputations directly caused by uncontrolled diabetes. There are more than 770 strokes, 590 heart attacks, 2,300 cases of heart failure. And unfortunately, diabetic retinopathy is the leading cause of preventable eyesight loss, at least in working age people. Now, I think you'll agree that all of these complications are completely avoidable, but they are continuing to get worse. More and more people are becoming diabetic, more and more drugs are being prescribed, and the complications are increasing at a rapid pace. So no surprise then that in the NHS, 10% of the overall budget is spent just on diabetes care. What might surprise you is that 80% of that budget is actually spent on treating these preventable complications of diabetes. And like I said, think back to the river story with the villagers. Is it time to rethink how we're approaching this situation? Because to me, and this is just my opinion, but to me it seems like we're always looking for more and more advanced solutions. As I've already mentioned, we've never had more access to more glucose-lowering drugs than at any time in history, yet the complications that come with diabetes are only skyrocketing, basically. And maybe it's just a time to rethink, like I said, the fundamentals of how we are approaching helping people living with diabetes, really. So, what is diabetes then? Now, if you are a dietitian, nutritionist, you're a doctor, you work with people, you might be a nurse, you work with people with diabetes. I'm not going to teach you to suck eggs here, but what I want to do is start at ground zero and build up together just to make sure that everybody is on the same page. And I especially thought this slide was relevant because in the last few months, we've seen all sorts of stuff published in the media saying things like salt causes diabetes, meat causes diabetes, climate change causes diabetes, and all sorts of things. So it can be really easy to get in a bit of a muddle as to actually what diabetes is. And, I know a lot of published research suggests that it's just a genetic issue and there's nothing that you can do. But really, when we look in all the clinical textbooks, look at the official definitions, so this is the World Health Organization's definition, and it's the same across the board. We characterize diabetes as a state of chronically elevated levels of blood glucose, or some people refer to it as blood sugar. And that's how we diagnose diabetes. Most commonly with the HbA1c test. There are other tests that can pick this up a little bit earlier, but this is fundamentally the definition of diabetes. And I want you to keep this in the back of your mind as we go through the next few slides, because obviously this informs what we can do downstream and have an impact and, minimizing the amount of people that progress with diabetes or maybe even develop diabetes in the first place. But fundamentally, it's elevated blood levels of blood glucose on a chronic basis, of course. So, this is a CGM graph that I took from a research paper. And the question is, which foods are most likely to do this to your blood glucose levels? It's not a trick question. Not here to catch you out. Should be fairly obvious. And most people would say, either carbohydrates or sugar or both. And if you've ever worn a CGM, you will know that to be categorically the case. Now, why is that? Well, the reality is that all carbohydrates increase blood glucose levels, absolutely all of them. Everything from refined carbohydrates to sugar, which is, of course, a refined source of carbohydrate, all the way down to the more complex carbohydrates. I don't think people tend to use that term anymore, but your brown breads, your oats, your pasta, your potatoes, these forms of starch or carbohydrates that we refer to as complex carbohydrates, those also increase blood glucose levels. Now, if you look at these images, what you'll notice is, of course, I've circled here, this is a glucose molecule. The sucrose one is table sugar, so that's basically just a glucose molecule attached to a fructose molecule, and that's what makes table sugar. Interestingly, though, the complex carbohydrates, so the carbohydrates that we consider healthy, fruits, vegetables, pasta, bread, all these kinds of things, are basically just glucose molecules all chained together, and that's really all they are. And it's the long chain that makes them more complex or more complicated, and that's what slows down their digestion into the bloodstream. But ultimately, all these molecules end up in the bloodstream. So they will raise blood glucose eventually. And that's why a ton of research says, like from this research paper, both the type and amount of carbohydrate found in foods influence glycemic control in people living with diabetes. Now, this is the case for people without diabetes, but in people with diabetes, it's even more exaggerated. So just keep in mind the type and amount of carbohydrates is what is most important. And like I've said here, all carbohydrates count when it comes to their impact on blood glucose. Now, of course, different types of carbohydrates have a differential effect, but ultimately the amount matters, which is why yet another research paper, these guys stated that the greater the carbohydrate intake, the greater the HbA1c levels at baseline. And also the reverse is true. So the greater the reduction in carbohydrate intake in terms of grams per day, the greater the decrease in HbA1c levels. Why? Because all carbohydrates end up as glucose in your blood. Doesn't matter how complex they are, doesn't matter how much fiber there is. Now, of course, the more fiber there is, the less dense those carbohydrates are. They'll take longer to get into your bloodstream, which is what that graph is trying to symbolize there. So they do take longer, but we do still see a bit of a rise. So this graph depicts that a lot more clearly, where we can see refined carbohydrates, big peak, big drop off. Why? Because a lot of the digestion has been done mechanically ahead of time, so it enters the bloodstream very, very fast, almost like sugar. And you can see the resistant starch line there represents our unrefined carbohydrates or our complex carbohydrates that we saw the molecules of just now, where they're basically just glucose molecules all chained up to make a really long chain. So you can see they still increase blood glucose levels fairly significantly, really, almost to the same level, but over a more prolonged period of time. So you still get that increase, but over a more prolonged period of time. So the amount, regardless of source, matters. And yet another piece of research said this: so reduced carbohydrate eating patterns are associated with significant reductions in HbA1c levels, and most importantly, they're associated with less need of glucose lowering drugs, which is kind of the whole point of this talk, especially 2023, moving into 2024, GLP-1 shortage, and now's the time to just rethink our over-reliance on all of these drugs, really. So, to make this more practical and relevant, this is the typical day of an average person in the UK. This is typically what people eat. At least the people I come across in my clinical practice. There'll be variations on this, of course, but this is just an example. And I've tried to be quite conservative here. So generally, a lot of people on average are having breakfast cereals for breakfast, usually followed by some toast, sometimes one or the other, and some coffee. And, a lot of people still put at least a teaspoon of sugar in their coffee. Lunchtime for a lot of people is sandwiches, crisps. They might have a banana if they're trying to be healthy. And of course, maybe another coffee, and maybe some more sugar in there or not. And then dinner looks like some kind of variation of this, which is, spaghetti bolognese, lots of pasta and stuff. Of course, this can look like, a chili with rice as well, and there'll be variations. But again, this is just a representative example. Now, you might not see any issue with any of those foods. If a patient was to report that they were eating those foods to you, maybe none of that would sort of flag in your mind as particularly problematic. However, just the foods that you see on your screen there, the total of carbohydrate or starch and sugar, as it says there, is 305 grams per day, which you may or may not know if that's a lot. You may think it's a lot or not a lot or whatever, but just to give it some context, if you read any of the sports nutrition literature, you'll know that in sports nutrition, they advise elite athletes to eat anywhere from 3 to 12 grams per kilogram of body weight of carbohydrates. Now, the reason they do that is because elite athletes are generally involved in, high intensity and long duration training. So they're constantly depleting their muscle glycogen levels. Okay. Now, there's only two places where your body can store carbohydrates. That's as muscle glycogen or as fat. So if you're constantly using up your muscle glycogen levels, it makes sense to eat carbohydrates to replenish the muscle glycogen levels, because, like it or not, a good body of sports nutrition or sports science published research suggests that muscle glycogen predicts peak performance, particularly for certain sports. Of generally the longer duration, the higher the intensity, then the more reliance on muscle glycogen. So the question is, since our patients are generally eating like elite athletes, like I'm 100 kilograms. If I was to eat 3 grams per kilogram of body weight, that brings me to about 305 grams of carbohydrates a day. But of course, I lift weights 3 times a week, so this may or may not be okay for me. But for our patients that aren't exercising, which is most of them, they are really eating like elite athletes, but they're not moving like elite athletes. So they're not having this high turnover of muscle glycogen, really. So can we be surprised then, if they are eating like elite athletes but not moving like one, can we be surprised that they are continuing to have issues, not only with managing their weight, but also developing things like fatty liver, non-alcoholic fatty liver disease, and of course having all of the issues with glycemic control? I don't think it's too surprising when you consider it in this context. So what can we do then, practically speaking? Well, if we start from the basis of, okay, blood glucose is determined by the amount of carbohydrates that we are eating, then we can focus our carbohydrate intake on what some people refer to as non-glycemic carbohydrates. So, these are things generally with low density of starch and sugar in them. So fresh fruit, fresh vegetables. Of course, there are some exceptions, like bananas have very dense in carbohydrates, but there are lots and lots of fruits and vegetables, unrefined versions, that are generally low in starch, low in sugar, and are generally considered non-glycemic carbohydrates because they have a minimal impact on glycemic control in people living with diabetes. And a lot of the research has shown, and this quote here is from a systematic review on the role of dietary fiber. So the more fiber people eat, up to about 35 grams a day, reduces HbA1c by about 2 millimoles. And this is why a lot of the epidemiological research generally shows that even in people with diabetes, if they eat more fresh fruit, fresh vegetables, and potentially whole grains, that generally improves their glycemic control, improves their weight, and everything kind of improves. On the note of whole grains, it's worth knowing, or it's worth pointing out, that generally I think there's a lot of confusion there. So in all of the epidemiological research that suggests that whole grains might be protective of diabetes and it might be useful in people living with diabetes, when you look at what whole grains actually are, we're talking about things like quinoa, buckwheat, barley, right? These very unrefined grains that the average person in the UK, and I would suggest the average person in most Western societies, they're not eating these things. What tends to happen, though, is the food industry will make a food like bread or bagels or something like this. So it's a refined product they'll put a little sticker on it that says made with whole grains. And the average person living with diabetes or the average person trying to lose weight will see the sticker and think, whole grains. I was told whole grains are good. That's got a whole grain sticker on it. So therefore, I can eat that and that's good for me. Now, of course, you know that that's not the case. But I think that's where a lot of confusion comes from. So we just need to flip that on its head, remind people about, okay, non-glycemic carbohydrates need to make up, perhaps the base of your diet, so less carbohydrate density, because fundamentally, if you've got less carbohydrates coming in, your blood glucose is impacted less, as you've already seen from a lot of the data and some of the graphs that I've shown. So this is where we focus. This is where we build our base from. Of course, the carbohydrates that we want to minimize and reduce as much as possible are the ones that are most dense in sugar and starch. So this includes everything like, potatoes, bananas, breads, bagels, muffins, pastas, rices, all of these foods. And it's not to say that people living with diabetes can't eat these foods, but this category of carbohydrate needs to be adjusted to personal tolerance. So one person may need to quite severely restrict this category of carbohydrates to get the clinical outcomes that they want to get, which, is probably a reduction in HbA1c, a reduction in weight, improvement in maybe things like triglycerides, etc. Another person, maybe somebody who is more active, might not need to restrict as much. So this category of carbohydrates, like I said, needs to be personalized and adjusted to help the individual reach the clinical outcomes that they're looking for. Generally speaking, though, we're going to be looking at reducing or minimizing this group of carbohydrates to achieve all of the downstream effects that we want. So again, just to make this practical and kind of real, and to give you an example, so here's an example of a recipe, so a tomato bagel. And again, if you work with patients or clients, generally speaking, this might not flag up as a red flag for you, depending on your knowledge and your experience level. But here's a graph, a CGM graph from a person that lives with type 1 diabetes. And on this particular day, they did actually eat this bagel for breakfast. Now you can see overnight, before they went to bed, they were a bit high. But then overnight, they went in the green on their CGM. And then they woke up in the morning slightly low and had this bagel. And you can see the impact that it had on their blood glucose levels. So it took them way above and beyond the green zone. And just, this person ended up with, 15, 16, 17 millimoles blood glucose. And of course, had to medicate that to bring it back down into the green as fast as possible. And this is just an example of how easy it can be to confuse, the whole carbohydrate spectrum, and why it's important to move people away from the carbohydrate dense foods and move them over onto the less dense foods. Now, this recipe was found on the Diabetes UK website, so I will leave that with you to consider why that might be the case. So moving on, so a simple way to communicate everything that I've mentioned so far to patients is this. Now, this graph was made by Dr. Unwin, and these graphs are available on the Public Health Collaboration website, but these are fantastic. Patients love them. It's just a really simple way to communicate this idea of the total amount of carbohydrates that you eat is the most important determining factor as to whether you achieve glycemic control or not. And of course, the longer term implication is if you don't achieve glycemic control, of course, you will develop complications down the road eventually. But again, this is just a really simple visual way. And all it's representing here is listing out all the different types of foods, different types of carbohydrates mainly, and listing out their impact on blood glucose in terms of teaspoons of sugar. Now, it's not to say that, say, whole grain barley bread is just like eating 5 tablespoons of sugar. That's not what we're saying. But we are communicating the fact that the total amount of carbohydrates eaten is the most important determining factor in your blood glucose levels or your HbA1c levels over time. And I believe Dr. Unwin used tablespoons of sugar because most patients understand what a tablespoon of sugar is, so it's an easy reference point for them. You can see here eggs and broccoli on the bottom, almost a negligible effect, and 0 in terms of eggs, of course, no sugar or starch in there. Broccoli has a tiny amount, and of course that lives in that category of non-glycemic carbohydrates. And then as the carbohydrates get more and more dense with starch and or sugar, sometimes both, obviously bread is made with sugar and a lot of starch, you can see as the density of carbohydrates moves up, so too does the impact on blood glucose levels. Now here's another list of foods showing a similar thing. So you can see basmati rice, 150 gram serving size, has a fairly significant impact on blood glucose levels in terms of how many teaspoons of sugar that might represent. Apple juice is of course an obvious one, and you've got banana on the bottom, which is of course nothing wrong with bananas. It's an unrefined fruit, but it is particularly dense in starch and sugar, so it does seem to have a significant impact. Now, that's not to say that people living with diabetes can't eat any of those foods. Again, the most important determining factor in whether a patient achieves glycemic control or not is the amount of carbohydrates eaten. Secondary to that is the type, but if you only do one thing, and you focus on reducing the amount of carbohydrates, then the glycemic control will improve. So with that in mind, if somebody wanted to eat some rice or they wanted to eat a banana, the simple way here, looking at this graph, would be to just reduce the serving size of those foods, which would reduce the impact on blood glucose. And again, I've used this with a lot of patients. It's really easy for them to use. They understand it and they can troubleshoot their diet themselves just by using this reference table. And again, all of this data is freely available, free to use, published by Public Health Collaboration, created, I believe, by Dr. Unwin. So full credit to them for that. Now, on the topic of carbohydrates, I know we've talked about a lot, and depending who you are, a lot of this may or may not be new for you. But if you remember only one thing, it's that the amount of carbohydrate is the most important determining factor in whether your patient living with diabetes achieves glycemic control or not. Secondary to that is, of course, changing the type or the quality of carbohydrates. But again, in the context of you're a healthcare professional, you've only got 20 minutes with a patient, you can only focus on one thing, right? If you focus on getting them to reduce the total amount of carbohydrate in their day, that will have the most significant impact on reducing their, on helping them achieve glycemic control, reducing their HbA1c over time, reducing their weight, and reducing their reliance on glucose-lowering drugs. So what about other foods then? Protein and fat. Well, fat has a negligible effect on blood glucose control. It does delay stomach emptying. So, if you eat a lot of fat with a lot of carbohydrates, the carbohydrates will take a bit longer to enter the bloodstream. But aside from that, if you just eat fat by itself, it has almost no effect on blood glucose levels. Interestingly, though, the most recent meta-analysis on dietary protein in people living with diabetes shows that in this group of patients, if they eat more protein, they over time will decrease their HbA1c, they'll decrease their weight, they'll decrease their blood pressure, and all of that can be achieved just by increasing the amount of protein eaten. Interestingly, postprandial consumption of protein does lead to the release of natural GLP-1 release, which may be partly why protein is so filling or so satiating. And generally, any successful weight loss diet will feature an increased protein intake at its core because it's more filling, fills people up, and people naturally eat less calories over time or less energy dense food over time, which in terms of people living with diabetes does mean they'll lose weight, decrease HbA1c, decrease blood pressure, decrease their risk of complications, which is, what we should be achieving most of the time. So, in my opinion, this is the ideal plate for people living with diabetes. And again, this is a visual resource produced by Public Health Collaboration. So this isn't my work. but this perfectly and visually encapsulates everything that we've talked about today. So the bulk of every meal plate should be protein-dense foods. We don't need to be scared of fat because in terms of glycemic control, it has a negligible effect, but definitely more protein than is typically recommended to achieve the higher satiety, the lower caloric intake, the weight loss, decreases in HbA1c, etc. And then after that, then the carbohydrates, as it suggests on this visual, we want to focus on the less dense carbohydrates. So basically, the sources of carbohydrates that have the least amount of starch and the least amount of sugar. So using fresh vegetables and fruit as our base. And then if we are having the carbohydrate dense or the starch and sugar dense sources of carbohydrates, just making sure that that makes up the smallest part of our meals or the smallest part of our day or the smallest part of our week, and just minimizing or reducing those as much as is needed to achieve the clinical outcomes. And again, that will vary for each individual. Some people will need to restrict that category of foods more, some people less, likely depending on activity levels. But again, this is a really good visual. I share this with all of my patients. They really like it. It gives them a really good frame of reference, especially when they get off track a little bit with their diet, which everybody does from time to time. And they can look at this visual and they know almost instantly exactly what they need to be doing. So, if you're wondering, this has been done in primary care already, so this isn't just something I've invented. Obviously, none of this is really new. It's all from published research, but it's been done in primary care already by doctors already. So, this image here is Norwood Surgery down in Southport, I believe, which is Dr. Unwin's surgery. Now, they have been doing this for a long time, and they published this first piece of research in 2016, where they followed 69 patients for about 13 months. And all the advice I've shared with you today, this is the exact advice they give them. All the visuals come from them. And basically that is just reduce total intake of starch and sugar. Now, the outcomes they achieved, on average, these 69 people lost about 9 kilograms in body weight, so they reduced their waist circumference by about 15 centimeters. HbA1c fell by 15 millimoles, which is a 19% reduction. Now, bear in mind, all of the research around dietary fiber suggests that the more fiber people eat, it reduces their HbA1c by 2 millimoles, and that's considered to be clinically significant, so much so that healthcare professionals all over the country, and perhaps rightly so, tell people to just eat more fiber because it will help. But approaching the diet in this way, which is reducing the total amount of starch and sugar, reduced HbA1c by 15 millimoles, so literally 10 times more. And of course, liver function improved, blood pressure dropped, likely because people lost weight. And the benefits for the surgery, look, in that 13-month period, they saved 45 grand in drug spend. 45 grand in diabetes drugs that they didn't need to purchase, because more of their patients are achieving glycemic control, and I believe they will have sent that money back to the NHS, which is absolutely huge because the NHS is always scavenging around for more money. So imagine if this was the default. Imagine if all the GPs in the country were achieving these sorts of outcomes in their patients living with diabetes. The cost savings would be huge, the impact for the patients would be huge, and I'm sure more doctors would enjoy their job more of the time because it can be stressful. So again, Dr. Unwin and co. at Norwood Surgery, they repeated the same study, if you like. So they did it again, and they published this data in 2022 in the BMJ this time. And this time they followed 186 patients for 33 months. So they give them the exact same advice, which is, again, reduce the total intake of sugar and starch. All of the visuals that I've shared with you today. But this time round, the outcomes, people lost 11.3% of their body weight, which, just to put that into context for you, clinically, we say that if somebody loses 5% of their body weight, that's clinically significant. Well, these guys lost 11.3%, so that's over double, of course. Waist circumference down by about 15 centimeters. HbA1c fell by 17 millimoles this time, which is a 26% decrease. They achieved remission in 51% of the cohort. And of course, what comes with improving your diet, losing weight, etc. The LDL levels came down, triglycerides came down, blood pressure all decreased, so their cardiovascular disease risk actually dropped. And again, the benefit for the surgery, aside from all the awesome results and feeling good about what they're doing, but they saved 68 grand. So that's 68 grand of money that they didn't need to spend on diabetes drugs, because more of their patients living with diabetes are now achieving glycemic control and getting these awesome results. And again, I would ask you, imagine if this was just the standard of care all around the country. I really think it can be, and I really think it should be, and I think potentially it will, could change everything. So, if you got any questions about any of that, I know it's a lot of information, a lot of dense information, but if you got any questions about any of that, then please do let me know. We'll touch on the subject of exercise and diabetes because it is important. So obviously exercise does play a role, and all exercise counts, everything from walking to running, but I just wanted to point out that strength training is actually superior to aerobic training alone when it comes to reduction of HbA1c. Now, in this particular randomized control trial, which was a fairly large one, they found that people that engaged in strength training, they did build a bit more lean muscle mass, which of course was an independent predictor of the reduction in HbA1c. Now, if you work in the NHS, you'll know that a lot of your patients, they don't go to the gym. They're not likely to join a gym. It doesn't mean they can't, but they're not likely to, and that can be for a variety of reasons. However, strength training doesn't have to mean going to a gym and lifting weights. It can mean anything, any weight-bearing movement at all. So even just encouraging people to carry their own shopping can be huge, because over time, they'll build a little bit more muscle mass. Obviously not as much as going to the gym, but working it into the daily routine over time can, I believe, have a significant impact. So how do we get people to exercise then? And I just wanted to touch on this because, again, working in the NHS, the average patient doesn't exercise regularly and perhaps is not necessarily motivated to do so. So how do we get people to want to exercise? And there are ways we can nudge them in that direction. Now, this image that you see here, the vicious cycle of failure, this is typically what most people do, most of us do. We all make these mistakes. So we start with the wrong why, which is, usually if a patient comes in and they see maybe a dietitian or their doctor or a nurse who will tell them, look, you're pre-diabetic, you might want to lose weight, or maybe you already have diabetes, it would help if you lose weight. And then, that kind of makes them feel like they should do it, right? So it feels like something they have to do. They kind of should. They don't really want to, but they kind of should. And that might work for a short period of time, but eventually they do fail. Until eventually then, the same thing happens. Something triggers them to start with the wrong why, maybe feeling like they should lose weight, maybe feeling like they want to get healthier. And all of these things, don't get me wrong, they all sound like logical reasons why people would start to change their lifestyle. But on average, when we look at the behavior change research, none of these things lead to long-term behavior change. Absolutely none of them. So where we need to get people to then is over here, to the successful cycle of motivation. And it's just about getting people in tune with almost like immediate gratification, which has a negative connotation in society these days. But the more people get in tune with, I went for a walk and actually I felt pretty good after that walk. The more people get in tune with that sort of thing, then the more they'll want to go for a walk because they want that good feeling. And this also applies to food. If every time a patient or a person eats a certain food and they get acid reflux and bloating, then over time they are just going to gravitate away from that food because they don't want to feel bad and they want to feel good. And again, the more we get patients or people in tune with all of those positive feelings and emotions, of course to do with exercise, but also to do with eating, the more they will just naturally want to engage in those behaviors. And when they naturally want to do it, then being motivated isn't even a question. So here's a simple example. Nobody needs to motivate you, or you don't need to use any discipline or willpower to get yourself to maybe watch a movie. or to get yourself to go out for a meal with friends, or, these things are just naturally enjoyable. People want to do them, so you don't need to use a lot of discipline and willpower. Now we just need to apply that to exercise and to diet, and we'll start to see that people are very self-motivated when they're in tune with that loop. It's worth knowing, by the way, that these graphics, I didn't make these graphics, these come from Dr. Michelle Segar, who is one of the leading behavior change researchers in this field, certainly when it comes to getting people to want to exercise. And this is what all of the behavior change research shows us, really. We just need to get people feeling like they just want to do stuff. So for some people, I lift weights because I enjoy it makes me feel good. Some people might not enjoy lifting weights, but that's irrelevant. They can engage in other forms of physical activity. And the same can be applied to diet as well. So supplements and diabetes then, I get asked about this a lot, and there are some evidence-based supplements that can help, and there are some that a lot of people say help that don't seem to have any evidence at all. So let's get into it then. There's just a few slides left, and then we are done. So the one that has the most evidence, in my opinion, is supplemental magnesium. So in 2016, a systematic review of 21 studies found that basically supplementing magnesium improves HbA1c in both diabetic and non-diabetic people, so improve their glycemic control. In 2018, a huge randomized control trial of 320 people showed that supplemental magnesium significantly improved glycemic control in people with metabolic syndrome. And again, in 2021, yet another systematic review found a similar thing. People supplemented magnesium, they reduced their BMI. Obviously, this improved their glycemic control, but that effect was mainly found in people with glucose metabolism disorders or magnesium deficiency or both. And of course, diabetes is a glucose metabolism disorder. So a lot of evidence there. So why does this work then? Well, there's two mechanisms here. The muscle cells and the fat cells. So there's a protein called GLUT4 that is responsible for moving glucose or carbohydrates from the bloodstream into the cells, into the fat cells, but also into the muscle cells to get stored as glycogen. Now, when there's not enough magnesium around, GLUT4 can't do that job as well as it could. So we start to get the onset of insulin resistance, really. And of course, if the magnesium deficiency is chronic, then that will just continue to get worse and worse and worse. In the pancreas, so the beta cells are what produce the insulin in response to carbohydrate consumption. So when the beta cells become deficient in magnesium, they do start to over-excrete insulin. So, you've probably heard the term hyperinsulinemia, and this is really where it starts. And this happens even in non-diabetic people. Now, of course, if it's a temporary or transient situation, it's likely going to have almost no clinical impact. But if the magnesium deficiency goes on chronically, as it does in most Western people, as you'll soon see, then we start to get the onset of hyperinsulinemia. We start to get the onset of insulin resistance at the cell level. And of course, if that just is left to build up and build up, can obviously negatively impact glycemic control. So what about food? So you would assume, well, surely you can eat magnesium-dense foods or foods that have magnesium in. In my opinion, I don't think in modern society it's possible to get enough magnesium from food anymore. I'm happy to be proven wrong. However, I just don't see that it can be possible. Now, the reason for that is because the soil, the minerals in soil have become more and more depleted over time. And that's not the case in all over the world, but in many parts of the world where food is grown, the soil has become depleted in magnesium for various reasons. And of course, this means the meat, the dairy, cereals, fruits, vegetables, all the food that is grown has less magnesium in it. Then when you add on top of that, all the processing and refining of the food actually reduces magnesium content of the food by up to 80%. Already you can start to see, well, we're probably not eating as much magnesium as we once did. And, if you remember the stats about, the increasing in prevalence of diabetes, this is all kind of starting to add up. But then even on top of that, if you layer on the fact that chronic stress, large intakes of caffeine, certain medications, even the consumption of plant-based foods, that are particularly high in things like phytates, oxalates, and lignins. All of these reduce the availability of magnesium in the body, either reduce the absorption or increase the excretion via the kidneys. So again, once you put these three factors together, this is what leads me to believe that I just don't think it's possible to get enough magnesium from food anymore, which of course might be feeding into the increased prevalence of poor glycemic control. Now, the big thing is we currently don't or can't test for this in people, especially in primary care in the UK. Now, the reason for that is because only 1% of the magnesium in your body is actually found in your blood. And the way magnesium metabolism works, essentially, is that your body will pull it from all of the soft tissues like your brain, your muscles, your bones. It'll pull it from all of those places to maintain the serum levels at all times. Now, in primary care, the main test that we use for magnesium testing is serum magnesium testing. And of course, 8 times out of 10, it shows up as completely normal. The only times it doesn't show up as normal is if there is an acute medical situation like refeeding syndrome or something else going on. But 8 times out of 10, it will show up as completely normal. And research shows us that a serum magnesium test will show up as normal, despite the fact that at the cell level, that person can still be deficient in magnesium. Plenty of research on that. Now, the test we need to be doing is red blood cell magnesium testing, which is available. We can do it, but in the NHS, we don't do it because it costs double the cost of a serum magnesium test. However, I would suggest that the cost of a serum magnesium test is literally wasted money. It's literally pointless. Eight cases out of 10. Because it's not picking up a cell level of deficiency, which is what we need to be picking up. So that's pretty huge. And it's worth knowing that literally up to 75% of people living with diabetes that have poor glycemic control are actually low in magnesium. Some of them show up as a low serum, but most commonly they'll show up as a normal serum magnesium, but they'll have low intracellular magnesium levels. Which, as I've already pointed out, is not currently being tested for. So this is an easy win. If we can test people in the right way, start to identify people that have low cellular levels of magnesium, and start supplementing them appropriately to help them achieve, improved glycemic control, reduced BMI, and if we couple that with all the dietary changes that we've already talked about, increased protein, decreased total amount of carbohydrate intake, we can start to make a pretty significant dent in this whole thing. And I really believe all of this should be the default approach, because fundamentally I just don't think that what we are doing is working, unfortunately. So other supplements, so berberine gets mentioned a lot. There does seem to be some evidence for berberine, so I managed to find 14 randomized controlled trials, all of which that found it does reduce HbA1c, not to any huge amount, on average about 0.72%. It seems to work via the same or similar mechanisms as metformin, which is by increasing cell levels of AMPK, which increases cellular glucose uptake. But the effect doesn't seem to be that huge. And particularly these 14 randomized control trials, I didn't think they were amazingly well designed. So, I'd like to see maybe more better, well designed trials to test this effect. But even if we assume these are are really well designed randomized control trials, the effect didn't seem to be that significant, at least not when you compare it against a reduced carbohydrate diet, or, a diet that's increased in protein, decreased in carbohydrates, add on some weight-bearing movement, if not strength training. All of that will have a far more significant effect than simply supplementing with berberine. But it does seem to have some kind of effect. Now, a few supplements that seem to have no effect. So probiotics was in the news recently. I think one research paper was published showing that it did have an effect. But overall, doesn't really seem to be a statistically significant effect. So I managed to find 28 randomized control trials, and when you take into account all of those trials collectively, we start to see a small non-significant effect on HbA1c of about 0.17%. Like I said, it's something, but it's statistically non-significant because the researchers couldn't be sure that this didn't happen just purely by chance. So probiotics don't seem to be a thing, but of course more research is needed. Research on the microbiome is still developing. We're still not really too sure what it all means, I don't think. So this might change, but as of now, this is the situation. Vitamin D I get asked about a lot. Now, of course, vitamin D is worth supplementing for lots of other reasons, but when it comes to glycemic control, certainly collectively 11 randomized control trials show that basically it has zero effect, and that's even after the research has followed up after anything between 8 and 26 weeks, which is quite a long follow-up, and they found absolutely no effect on glycemic control whatsoever. But again, there are other reasons why patients may want to be supplementing with vitamin D, but just know that when it comes to glycemic control, vitamin D isn't going to be one that helps them. So to summarize everything then, because there's a lot of information, but really we've only talked about four things, just four things. So the first one, the biggest opportunity when it comes to improving diabetes care and getting those amazing outcomes, which should be the default, really. That should be our default go-to. So diet is the biggest opportunity, and all you need to remember is if you decrease the total amount of carbohydrate, if that's the only thing you can focus on clinically, then your patients are going to do great. And that will look different for different people. One patient might need to go from eating a loaf of bread a day to a quarter of a loaf of bread a day. Another patient might only be eating a couple of slices of bread, and so their adjustments will need to be different. But total amount of carbohydrate is the biggest opportunity to improve things and help our patients improve their glycemic control and avoid all the complications. The second thing then is movement. So weight-bearing movement has the biggest effect, but that said, it all counts. So if your patient or your client can only walk, get them walking. Walking counts, running counts, it all counts, but weight-bearing movement has the biggest impact. Number three then is obviously we want to stay patient-centered, and really if we can help our patients enjoy the movement that they are doing, or if we can help them enjoy a reduced carbohydrate diet, then they are more likely to stick to it, not only in the short term but in the long term, and that's really where the big gains are made. So we just need to help patients connect the dots on why they enjoy things, movement, diet, etc. And then the fourth thing we mentioned was just a few supplements that have a good amount of evidence behind them and may be worth considering, probably only though after you've ticked the first three boxes. The biggest one is magnesium supplementation, definitely has the most evidence, followed by berberine, which may or may not be helpful, but definitely want to focus on the three big rocks. So any questions about any of this stuff that I've shared, feel free to reach out and ask me. Yeah, I'll catch you on the next one.